Hi, good afternoon, everyone. Thank you for joining us on today's Fireside Chat with Dr. Peter Antall. My name is Lisa Feely, and I'll be facilitating today's Fireside Chat, and we're going to talk about the disruptive innovation of telehealth. Our objectives really for today's session is to learn about kind of the history and future of telehealth, and then really talk about potential growth and challenges we're all starting to hear about and see, and how telehealth is really going to impact the future delivery of our healthcare and impact our customer care, right, and the patient experience. And then Peter is going to also discuss how all these different technologies will really complement telehealth as we move into 2021 and 2022. So, Peter, what I want to do is first, I want to talk a little bit, introduce Amwell as a global telehealth company, and you have been responsible for a full clinical direction of the entire platform as well as clinical guidance. And I know that you are the founder and president of Amwell's Medical Group, which really I think is the nation's first telehealth medical group. And in your role, you're managing thousands of clinicians all across 50 states. So just a small job, right?
It keeps me up a little bit. Yeah.
Welcome. Thank you for joining us for today's Fireside Chat. So I have to start with, I know there's a whole bunch of people out there who have their definition of telehealth and telemedicine. Can you chat about what is telehealth and how is it different from telemedicine as well?
Sure, absolutely. And it is true. There are a lot of different definitions out there. I think we think of it pretty simplistically. The telehealth is the use of technology to facilitate meaningful healthcare interactions or healthcare delivery. Telemedicine is a subset of telehealth, but I think in our view, telemedicine really represents only part of what can be done through telehealth, the really active provider to patient interaction, provider being often in that definition a physician, but not exclusively. But telehealth is so much more. Telehealth is about interactions provider to provider. They're about team-based visits. They're about interactions with allied health providers and the like. So it really is about just bringing technology into the healthcare arena and using it for meaningful encounters, meaningful care, et cetera. Some examples are up on the slide. Some of the things that we do at Amwell, different forms of what we would call telehealth. We have the on-demand telehealth, which I think in 2020, everybody in America at least became familiar with. That's really typically primary care, urgent care oriented, on-demand. Patient has an acute need or an urgent need. They can come on and interact with a clinician to have that need met at a distance. They can do that on a smartphone, a tablet, a computer, however they wish to do that. The next column over really represents care with known providers. So we call that follow-up care. So that may be a primary care physician. That might be a registered dietitian or a cardiologist who is seeing his or her patients on an ongoing basis, again, electronically. And the patient very well may be in the home or at the workplace. The provider may be in the office setting and performing what we call hybrid care, or the provider may be dedicated to telehealth and solely seeing patients in this manner. When we get to the right side of the screen, we're really talking more about hospital-based and what might have been in the past called traditional telemedicine. So things like telestroke, maybe the far right column. Patient comes into an emergency room with stroke. They might benefit greatly from administration of a clot-busting agent, but require a neurologist to help make that decision, because in some circumstances, it might not be a stroke, or it might be a stroke caused by hemorrhage where a clot buster would actually make matters worse. So that's a wonderful use case of telehealth or telemedicine. And then finally, the third column, the column one from the right, really represents that this type of care in a hospital setting, whether it's provider to provider or provider to patient, can happen in a variety of settings, including subacute settings. So skilled nursing facilities, step-down units, surgical centers, things like this can also make use of telehealth to benefit patient access to care.
I have to ask in between here, in talking with this all this information up, I had heard and studied that over nationally last year, 4,347% increase in the use of healthcare claims through telehealth. And then some hospitals, upwards of 40 to 50% telehealth growth. Do you have an idea, or do you have a feeling, as we kind of go through in our discussion, how much of it is on that left side of the screen versus how much is on the right side of the screen, and where hospitals are seeing the most growth?
Yeah, I think specific to COVID, it was more so the left side of the screen, but that is not to say that the right side was not also used. So the acute care, there were steps made to limit the exposure of providers and other specialists to an active COVID patient. So that was one use. We literally had providers that were sitting at the local nurses station on a computer visiting with a patient just down the hall in order to limit the ins and outs into that room with a contagious patient. There was, a lot of advancement in hub and spoke models, bringing specialist outlying hospitals, particularly for the ICU care. So there was plenty on that right side, but I think the explosion was more so on the left. We really had a crisis in March, April, May, where ambulatory medicine more or less shut down, and patients needed to be seen, and they didn't always need to be seen for COVID. Many of them needed to be seen for their diabetes or their hypertension. So providers really scrambled, both us, the vendors, as well as providers with known relationships in brick and mortar, scrambled to use telemedicine to meet their patients' needs.
Yeah. There was nothing like a quick jump there for everybody, right?
It was a wild ride. It was a wild time.
Well, we'll move on to our next question, which is really, can you now, we all lived through, 2020 and the pandemic, and, it's not quite over yet, but can you share a little bit, even going back further on the history of telehealth, and really what have we learned, I guess, and what are we to take away for helping us move forward better?
Yeah, great questions. I might start with let me start with something else, and then we'll talk about what's on the slide there. The history of telemedicine is a long history. There were efforts going on back in the 60s, and actually a friend of mine was involved in these, running closed circuit TV from Mass General over to Logan Airport, which is in East Boston, and usually you have to go through a tunnel to get there. So there was telemedicine happening in Australia 50 years ago to distant sites where there were miners or loggers or others who needed care. So there's that.
The astronauts needed help too, right?
Right. That's right. In fact, I have a colleague who was working on a robot that could do an appendectomy in space if that ever became a necessity. So fascinating stuff. But really, I think the history is things really ramped up more recently. So over the last 20 plus years, think of things like teleradiology, telepathology. These were happening back in the late 80s, early 90s, if I'm not mistaken. Telestroke really became the biggie in the aughts, the big telemedicine use case that really became prevalent and really made a huge difference for patient care. Since about, 2000, American Well was founded in 2006. And at that point, there were no smartphones, but we were founded on the idea that we could connect patients wherever they are and providers from wherever they are, and we connect them by computer to have a meaningful video encounter. And of course, smartphones and tablets really changed that. All of a sudden, we had even better tools for these interactions. So things have really evolved since then. And then I think if we go to the slide, Dr. Topol, Eric Topol, who's a well-known futurist based at Scripps in San Diego, he made a bold prediction back in 2017. And the prediction was the crossover point. He predicted that we would cross over right around the end of 2023 and see as many virtual visits as brick and mortar outpatient visits. This was not received well. People didn't believe it. I thought he was out there. But as we're going to see in one of the subsequent slides, we briefly hit that crossover point during COVID. Now we've receded back a bit from that, but this curve may be advancing more quickly than we ever thought.
I was going to say, I was going to bet that we already passed that last year. So.
We hit that moment, and I will show that in a subsequent slide. The one other thing, you mentioned learnings, or what have we learned during this journey? We've learned that healthcare does not move quickly. Healthcare does not tolerate change readily. We've learned that there's a lot of inertia in provider ways and provider workflows, and some of that is for very good reason. Providers are scientists, physicians, and other providers. They're taught to use evidence-based thinking and to rely on studies and evidence to change, if there's going to be changes in practice. But right now we're in a place where technology is moving faster than you can do research studies, and so we're having to be a little bit more nimble. We're having to take leaps of faith, do it safely and carefully. But these are opportunities for us to really advance the way our healthcare system works and how healthcare is delivered.
Yep. No, I agree. So if we can go, we'll take it from there and we'll say, so mentioning some of that, and that is one of the challenges, right? That giving that fast growth, really the pandemic pushed us into it. So, not only kind of where do you think we're headed, but how do you think we best get there? I think a lot of people in the audience is not only obviously many of our owners, our healthcare leaders that are in hospitals every day, but I think a lot of us are helping them to try to plan, what is it you need and how do you do this? Is it command and control centers? Is it, telehealth facilities with ability to incorporate, the right kind of technology? Is it, or they're the, Fitbit type, everything that pulls this all together. So with that challenge, where are we headed?
Yeah, the big question. So I did reference earlier that I was going to get to our data, and let me clarify, this is not our Amwell's data. This is our national data. The yellow line represents the spring peak of COVID, and these are weekly case numbers, test positive case numbers. The initial spring peak, the subsequent summer peak, and the beginning of the fall to winter peak. This data is a little bit behind. And then the bar graphs, the blue bar graphs, represent the percentage of ambulatory visits that were performed virtually. So if you look right at the end of March, beginning of April, we surpassed that tipping point where 52% of medical visits in the U.S. were done electronically. Pretty amazing. And then we began to see some drop off. And that drop off, some of it wasn't that the peak really dropped into May, June. It's that, we adjusted to this new normal. Offices began to figure out how to segregate their well patients and their sick patients and see them. Urgent care centers came online for seeing more of this. Testing centers came online so that we could test in different ways. So things kind of settled down, and the percentage of visits happening electronically began to come back down, and it's kind of settled in since then. But it's been an explosive year. It really has been incredible. I mean, when our CEO is on the phone with the CEO of Cisco begging for more servers because we can't get them on the open market and our servers are about to overheat from all the traffic, it really was one of those, really incredible moments. So telehealth exploded. Patients realized the value. Patients were already, by and large, beginning to realize the value of this kind of home-based or work-based telehealth. Providers, though, were the big story. The providers realized the value. They said, wow, my patients need to be seen, but I really want to keep, my staff safe. How about I see them electronically? And as they tried it, they realized this is a very effective tool. So much of healthcare doesn't require an exam, doesn't require a new diagnosis. So much of healthcare is just maintenance of current state and current conditions, most of which is very, very amenable to telehealth. I would add that I think there's a massive shift happening in the behavioral health space. We see therapists closing their offices and intending to close them permanently. So might not be good for those in the medical office-based business, but it's a real sea change that they're realizing they're really not lacking much of anything in seeing patients electronically. So big changes. If we think about where are we going, I think I'm going to address this in the next question I think you're going to ask as well. Chronic disease. So telehealth so far has been nibbling around the edges of the big spends in healthcare. We've been doing urgent care and therapy and a little bit of psychiatry and diet and nutrition and wellness programs. Telehealth is really now beginning to gear itself up to address diabetes and hypertension and COPD and all of these things in a much more comprehensive way. New models are being built. Virtual primary care is the hot new thing in the health plan space, where we are actually endeavoring to take on chronic care and wellness for patients who, for whatever reason, don't have a primary care physician, or the medical home model hasn't worked for them. Infrastructure as well. So on the inpatient side, on the subacute side, we're seeing more build out of infrastructure that takes into account the need for telehealth endpoints. Maybe in every exam.
Right. What I was going to say is, I mean, clearly I don't have a crystal ball. You're definitely more in the middle of it, especially with all your doctors across the country. But what I'm hearing, what I'm seeing, and I guess just being a mom and someone who obviously it's easier to get telehealth than it is to drive 25 minutes to a doctor for something that you don't really need to necessarily be seen for. What I'm hearing is, and we're going to address it a little bit here in the next question, is it has been more positive than negative. I mean, there are some obviously challenges, I guess, when we get an infrastructure in very rural areas, right, and having access. But most people that I've spoken to, and I travel a lot, you know, all across the country and speak with people too, it has been positive. So I think that it's fantastic, you know, that we have this and that you guys have, those of you that are really providing that infrastructure for us to have a platform have done a great job overall in 2020, 2021, trying to keep up. All right. Well, so going to that next question.
Lisa, one more quick thing. It's different infrastructure. You know, it's and again, everything we think about it in a sort of a hybrid manner. It's not that we're not going to need inpatient beds. It's not that we're not going to need emergency room beds or subacute beds. Of course we will. But it's thinking a little bit differently about how do we bring the specialists to the outlying hospitals? Who needs to be inpatient or who could be managed at home with aids and technology to free up some of those beds. It's building out the electronic infrastructure. You know, you need good bandwidth in order to have a good telemedicine program. You need good connected endpoints or good bandwidth throughout the entire hospital. And hospitals are known for having a lot of cellular dead spots or Wi-Fi dead spots. So, and we've been there. We've worked with Jacksonville Naval Hospital, and that was one of the things they did is they had one of those people going around with a wand looking at bandwidth in every room and every hallway.
I think it reminds me, Peter, when a lot of people even 15 years ago said, oh my gosh, you know, some of these companies like Blockbuster, you know, or you're not going to need people anymore in manufacturing because robots are going to take over all this. I think you made a statement that I completely agree and appreciate. It's just a different way of looking at it. I don't know in my lifetime if we're ever going to not have a need for emergency beds and all this. I mean, right, we're going to have that need. So that, you know, that goes to just a lot of stuff of what you just discussed. Tell me more about the positive impact in the future. How so? Like you were just speaking about how we start dealing with more mental and behavioral health and all that. Yeah.
Well, we have so many problems in our healthcare system, right? Our healthcare system is so broken in so many ways, and we're not going to solve all those problems. But telehealth is a wonderful new tool in the toolkit of every organization that they can use to help mitigate some of these problems. So, to give you a few examples, access to care, that's a real problem. Even if you have a medical home, you may not be able to get in for a week and a half when you have a fever and a cough. Either it's going to get better by itself by that point, or you're going to be in deep trouble. So access to care, coordination of care, interoperability, so data is flowing back and forth so providers can have an informed visit and patients can get the data they need and share the data that they need. Challenges with mobility. So how do we help better care for those that have transport challenges, those that have walking or other challenges? You know, so many things that can be done. And like I said before, we are reinventing some of the models. When we're participating in virtual primary care, people have a tendency to say, well, gosh, you can't do a full exam virtually. And we say, sure, there are a few things, a few limitations on the exam for sure. However, what we can do is more readily bring in data from wearables and other devices in the home. What we can do is see the home itself, if they're in their home, and see the socioeconomic challenges that they're facing, or see what's in their refrigerator. If they're a diabetic, have them walk the phone or tablet over to the refrigerator. We have the ability to merge traditional model of primary care with other models of disease management. So all of a sudden, we don't just see the diabetic and make recommendations and change meds and do some labs and send you off and say, we'll see you back in 6 months. We borrow from diabetes care management or disease management program methodology, and we monitor and we have alerting, and we're building towards a future where we can nudge the patient and do other things like this. And when I say we, I mean the industry itself. I'm not really sharing Amwell itself's strategy, but there's so many opportunities for organizations like ours to move in these directions.
Very good. No, I find that fascinating. I mean, and we're going to talk a little bit about these technologies to come, but I imagine, and again, not just Amwell, but I imagine many of these platforms out there can, and correct me if I'm wrong, can coordinate very well with the wearable devices and/or these, even the pills, I guess, we're swallowing to tell you that we've taken our medicine or we haven't taken our medicine. It's getting crazy.
When you start in the electronic realm and, you're a technology company, the barrier is a lot less to innovating like this and to finding new and hopefully better ways of integrating what we know about the patient, what services are available to the patient. They may be eligible for a weight management program through their employer or their health plan. We can make those seamless referrals potentially, all kinds of ideas. And I'd be remiss, Lisa, if I didn't at least mention, since we're talking about what's the future looking like, there is so much exciting work going on in AI and management and crunching of data about patients, making that data relevant and actionable. Chatbots, other things like this that can provide meaningful guidance and navigation. Devices.
You're answering my next question already for me, Peter.
Oh, is that right?
No, that's right. So that's where I was going to go next. I love it. Was if we go to the next slide, and this could be more maybe because I doubt you can speak to all your other companies out there. But what is Amwell really doing specifically to help hospital teams and drive that better patient experience? And you just were talking about it, leading to more innovative and value-based services. So, and maybe again, Amwell, and what can I count on, I guess, if I'm a hospital leader from your industry?
Yeah, I mean, I think our goal is, and let's go back one slide or two slides. Our goal is to make technology widely available and user-friendly for our partners. And our partners are often hospital systems, but our clients are sometimes health plans themselves, sometimes they're technology companies, sometimes they're employers directly. But we really try to provide an ecosystem and a navigation capability and scheduling or brokerage between the needs of the patient and the availability of the provider. We try to do so in such a way that it's seamless, that it's easy to use, that we help arm the patient to be able to bring all the data they need into the visit. We help arm the provider to be able to extract all the useful data and other things that they need to make decisions and render diagnoses. We bring integrations and all that. I mean, really, ultimately, we do all of that on a white labeled basis under the brand of the owner of the enterprise platform. And we like to think of ourselves as sort of the Intel inside. We're there with the technology, but we put their logos and their coloring on it and provide an experience that is seamlessly under their brand.
I was just going to say, so you're the seamless foundation behind it all.
Yeah, we try to be. That's the goal.
That's great. And then though what we're going to talk about next is then comes the regulatory, right? And all the So if you'll go ahead a few slides, that's where we're headed next. There you go. So now what?
Well, yeah, I put the slide up. The idea was ending on the idea of what are some of the barriers that still remain, or what are some of the barriers that we've been working to overcome. And you have to go to regulatory and legislative. Those are and have been significant barriers over the years. So I think we've made a lot of progress, but there's still work to be done. We're active in Washington and working. Some of the priorities are around reimbursement. Medicare reimbursement has typically been hampered by some difficult requirements that the patient be in a rural region and they present to a clinical site. So it really is I think, that those regulations or that legislation that's in the Social Security Act, that really looks at the old model of telemedicine happening in a clinical site from another clinical site. And we're really trying to open the eyes of those in Congress to understand that we can provide real value at any site, and it doesn't need to be in a rural region. We can provide value in the home. The good news is CMS now has data because that provision was waived since the emergency declaration, and there is now data on what care in the home looks like. And so we're hopeful that they see that care is being delivered in a safe and effective manner, that outcomes are being maintained, and that this is not an outlet for fraud, waste, and abuse to occur if you have good, strong processes in place. Other work's being done in Medicaid. We have 51 different Medicaid agencies, all with different rules and requirements and reimbursement policies. So having some consistency there is a real challenge. Licensure still to date is by state, and we're in a much more electronic and mobile world now, where we're advocating for licensure portability. There is a compact that involves some of the states and allows for a little bit of a streamlined process for additional licenses to be obtained, but there's still work to be done there. And then I would just finally say there's still a little bit of work in commercial about reimbursement. That area has gotten better. Still a little bit of work with the DEA and controlled substances, especially in an era where we have such a substance use disorder problem with opioids. Sure would be helpful if we had some modernization there. And so lots of work to be done. Outside of commercial, I think it's really change management. It's building out new workflows. It's engaging providers and all that. But I think the horse is coming out of the barn here on this one. I think everybody, especially during COVID, has realized that this is a big part of the future of medicine. And so it's either disrupt or be disrupted at this point.
Right. So I know this will be a tough question. You can pass if you want to, but if someone kind of said, hey, if you really had to summarize it all for those that are, again, trying to, whether they're a CFO or CMO in the hospital, clinical side, operations side, procurement, trying to figure all this out, what 3 messages would you say on the positive side should be the takeaway for telehealth? And then what 2 or 3 would you say, boy, here's our biggest challenges that we hope in maybe 2021 going into 2022 we can see differently if we can get them changed?
Yeah, I'm writing myself some notes here. Number one message from my perspective is this is just healthcare. This is not some special side world of healthcare. This is using providers and their skills to efficiently, hopefully, depending on the model, efficiently provide good care. So I think that's the front and center message. Beyond that, this can be a differentiator for your organization. If you're requiring everyone to come in under every circumstances and wear that paper gown and sit on that exam table for 30 minutes, it's going to be problematic for you. Patients really want a significant percentage of patients out there have done this, tried this, used this, and really want this kind of care to be the norm, at least for a good segment of their health needs. And finally, I think the other positive is it's not that difficult. It does require some thought. It does require some workflows, but I've seen organizations do analysis paralysis and committee after committee to decide on one use case and roll it out 6 months from now. It's not necessary. The technology is there. The methodology is there. There are organizations like ours that really know how to help you get this done. And so I recommend organizations not wait. On the negative side, you do have to be cognizant of the regulations, not just the reimbursement policies, but the various regulations that may exist. I mentioned some nuances about DEA and controlled substances. Some states have other controlled substance lists that are state specific. But you want to go in with open eyes. Number one. Number two, you do have to develop some institutional quality oversight that is cognizant of the telehealth visits, that is overseeing the telehealth visits. Again, this isn't that difficult, but it is something that's important to do. And then finally, you need to work with your payers. That landscape's getting much better, but you need to work with your payers to make sure that if you're going to do this, you're going to get paid. Or ideally, you work within elements of your care that is already bundled or already value-based arrangements, and that's a low-hanging fruit. That's always a great place to start.
Fantastic. Well, I know we're wrapping up here, so I'll go to the next slide, but I'll ask while that shows if there are any questions from our audience here, again, wrapping up, this is if you want to learn more about Amwell, this is where you go. We really appreciated Peter for the fireside chat, but if there are any questions out there, we would love to hear from you. And I'll ask one more question I have of Peter if there are no other questions from the audience. So we'll wait here for a few seconds. While we're waiting on that, Peter, you had mentioned, and I'd love to just quickly summarize while we have a few minutes left. How do you see IoT and AI and all that also playing into what you're doing? I mean, boy, are we a lot going on in the technology space.
There is. I honestly think we're in a bit of a renaissance period, and I know it sounds kind of cliche, but it's the health IT space is just popping right now. With there's noise, but there are some things happening that are just incredibly exciting. I'm particularly excited about natural language processing and automated translation. That is not futuristic. That's here today. I'm particularly excited about the advent of more and more wearables and the data that they can produce. That's not just how many steps you take. I mean, for some patients, that's valid info. For many patients, that doesn't change their healthcare treatment much. But if we can all of a sudden get an oxygen level in a COPD patient, if we can get real-time glucose monitoring results, if we can get an indicator like a peak flow meter indicating that an asthmatic is in crisis, there are really amazing things that can be done. And I think where the AI comes in, I think that really comes in right now, at least, in the context of gathering data asynchronously with a patient. And I really haven't talked about asynchronous care today. That's another area of telehealth that's blooming, particularly maybe in the behavioral health space. But if we can gather answers to questions asynchronously, either because a patient has a new problem and they're inquiring, or maybe we're checking in on a patient with a chronic condition. And, there are already AI machine learning algorithms that are helping us to figure out what questions are most meaningful and what questions are most actionable, and helping us to refine. It's actually scary as a physician if we design what we believe is a wonderful question set and to triage somebody with, let's say, a cough, for example, and then we run 1,000 of these algorithms and have a way to assess outcomes. The machine learning can tell us which of those questions was useless, or might even be able to suggest that we're not asking something that we should be asking. So it's really fascinating technology.
It's phenomenal. We did get one question, so we're being asked from the audience. Actually, I should say you're being asked. So, how well are the elderly adapting, do you think, to telehealth? And how is access as well for those that are in the underprivileged and very rural markets too? Are they able, those that don't have access to computers?
I mean, our goal is to make access seamless and easy for everyone. And these are two populations that can be more challenging. Examples of what we've done things like falling back from smartphone to standard phone, doing phone only, allowing a patient to enroll and put in their information, even from a wall phone, through use of a customer service representative who can walk them through, enroll them in the platform, and get them into a visit. And there are others, language translation and other things that we've done to improve access for those that might find access challenging. I would say that the elderly population has been less exposed to telehealth because of the Medicare restrictions to date. But once those restrictions were at least temporarily alleviated, we saw great progress and great acceptance in that population. So that's encouraging and exciting. I mean, obviously, there's a cutoff when you get above a certain age. and I don't know what that age is, but let's say 80 or 85, technology might be a little challenging still. But in the 65 to whatever that age group is, generally patients we find are plenty capable and often have the proper devices to do this seamlessly, like an iPad or a smartphone. On the underprivileged, our biggest and rural, our biggest challenge is bandwidth. And I know that's getting better, and we have 5G rolling out across the country, but there are still pockets where bandwidth is poor. And so we certainly support FCC efforts to work towards a future where that's not a limitation.
Terrific. Well, two things, and a person in the audience, I'll get to it in a second too, is about IoT. But before we get there, you mentioned something earlier too. I think we're seeing access, and I'd like to know if you're hearing that more too. For those that don't have computers or don't have some access to the broadband, if they can get to some public places like a library, we're seeing more and more libraries have private rooms and integrating with medical that I would have just never predicted 10 years ago. But when we're seeing some master plans of libraries come out, they're integrating, again, it's just amazing. So are you starting to see that as well?
We are. It's not happening explosively in our experience, but we are seeing it. We've participated. We have traditionally had a line of kiosks. We've seen kiosks placed in homeless shelters in far distant island regions and islands in Hawaii. We've seen mobile kiosks gone down in the Houston area after a hurricane and be used in that manner. So certainly things are coming. We also have seen more of this at large employer sites. So that's another aggregator as well. It doesn't necessarily serve the underserved population in that setting, but you can sort of aggregate care around an employer site.
Perfect. And then the question got asked is IoT, what is it? So IoT is the Internet of Things, and it's just how is everything connected to one another. And that's just the explosion of all the devices. I mean, I think, and I don't have it in front of me, but I was teaching another class not long ago where what we predict often doesn't come true for the short run. Like we think stuff's coming quicker in the short run than it is long run, but then we typically underpredict what we're going to see in 10 to 20 years. So I think, again, when it comes to Internet of Things, I think we gravely underpredicted the number of access to all the, like you said, smartphones. I think a lot of people knew telehealth existed, but can't even imagine how quickly smartphones and these wearable devices and everything have exploded. Is that what you're finding when you talk about Internet of Things and the connection of the devices and all that too, Peter?
Yeah. I think we're focused a little bit more on medical and non-medical monitoring devices. So wearables, like the Apple Watch or the various rings and things like this. And then, of course, the medical grade traditional monitoring. Those are the lowest hanging fruit, I think, right now. Certainly, we're looking at the household to determine what is the best easy endpoint in the home setting. I mean, and I'm just thinking out loud here. This is not an Amwell's product or anything like that, but I think from my personal perspective, I don't think I want my toaster to be taking my pulse ox every time I push the button, to put the toast in. However, there might be, and this again is not Amwell's strategy, but there might be an opportunity where a small television on your refrigerator might be able to monitor you in some way. I don't think we really know what's going to be monitoring us in 5 years. It may be our belt, it may be our shoes, it might be our glasses. But
can I get the one that tells me to stay away from the chocolate fudge ice cream in the freezer?
Yeah.
Leave it alone.
We'll be monitored. We also have seen what happens with retargeting of ads when we're on the web. I mean, things are going to evolve, and our hope is that we can make meaningful, good use of this data and have it result in better clinical outcomes.
Well, I know we're starting to wrap up, but one last thought, or if, again, will it tie into telehealth some way? I just think of one big trend is the 3D, right? 3D printing of medicine. I mean, there's actually 3D pills, and people are saying, but that's not out yet. That is out. I mean, that is happening now. And back to the ability to monitor that, is it your hope that maybe by, 2023, 24 or quicker, we're actually seeing telehealth connect in somehow to this information so that we can track if people are taking their medicine, not taking their medicine, how effective stuff is?
Yeah. Oh, yeah. Of course. Yeah. I think just in the industry in general, there's an increased focus on what happens outside of visits. And how, if we want to achieve better outcomes, some of what we need to do is we need to nudge patients along to be compliant. And that might mean monitoring their medications. That might mean making sure they got their prescriptions filled, that they were covered, or they had the money to pay for them, and many, many other things. Are they exercising? Are they checking their blood pressure regularly? Are they taking their blood glucose regularly? There's such promise there. I would say on our rate, 3D printing per se is not necessarily on our radar unless it pertains to this, but there are some exciting things happening in the 3D printing arena with regard to sort of orthopedic care and joints and other things like that.
Right. But the goal is that this telehealth, the more that we're engaged, you're going to try to have a more longer term relationship so I can log in.
Oh, yeah.
And talk to. That's great. Okay, well, if there are not any other questions, thank you so much, Dr. Antall, for joining us today. And again, from Amwell, and any information, they can just go to your website and try to learn more, right?
Absolutely. Absolutely.
Thank you, everybody. Have a great day. Thank you, Peter.
Thank you.